Hello, everyone, and welcome to this first Neuro Lunch and Learn of 2019. Although you might not be watching this at lunch, it could be 2 o'clock in the morning, but hoping to make things accessible for people of all shifts who can't make it to the daytime stuff. So, to talk about disorders of sodium that are really common to the neuro population. These include SIADH, cerebral salt wasting, and diabetes insipidus, as well as a bit about hypernatremia. So, sodium level, why is it important? Well, around 17% of neuropatients experienced hyponatremia, and a wide range between 5 and 51% of neuropatients experience hypernatremia. As we'll see in our case study later, the same patient can experience both high and low sodium levels. We worry about our patients in particular because quick changes in sodium can have an effect on cerebral volume. Fluctuations can cause neuronal damage and cerebral edema. So my first case study is actually a true story. So in 1999, Martin Lawrence, the actor, he decided to go for a jog in 100-degree weather. He collapsed and was found with a body temperature of 41.9 and was unresponsive for 4 days with a TBI after the fall. So imagine you're assessing him and you notice a low urine output, high blood pressure. His serum sodium is low and he has generalized edema. So it turned out that Martin Lawrence had SIADH. This stands for Syndrome of Inappropriate Antidiuretic Hormone Secretion. See, ADH normally tells the body to retain water, and too much ADH tells the body to hold on to too much water. This causes what's called a dilutional hyponatremia, which I'll go into on the next slide. These patients are puffy, with too much water on board, and their urine output is low. On the left, you've got a picture of a well-balanced patient with normal amounts of water and sodium. In SIADH, the body is being told to hold on to the water, and the ratio of water to sodium ions is out of whack. Too much water, not enough sodium. So the hyponatremia is a dilutional hyponatremia. There's not enough sodium to balance the high amounts of water. Pretty much anything in the CNS can cause SIADH. It can be meningitis, a subarachnoid hemorrhage, Guillain-Barré. Patients with chronic lung diseases or lung cancer are more susceptible, as are some patients on common meds such as hypoglycemic meds, NSAIDs, Tegretol. Pituitary tumor surgery or any other neurosurgery can also cause SIADH. Clinically, when the hyponatremia from the SIADH is mild, say in the 120 to 129 range, patients tend to appear asymptomatic, especially if it's a chronic issue. But if the sodium has dropped below 120 in about 2 days, the patient may be dizzy, forgetful, confused, and lethargic. So this part is interesting. It's not just about how low the sodium goes, but how quickly it happens. Severe hyponatremia might be seen in patients who have a similarly low sodium less than 120, but it happened quickly, in less than 48 hours. Because it happened quickly, they're at risk for seizures, permanent brain damage, respiratory arrest, or death. The treatment probably sounds familiar. Fluid restriction, maybe slow 3% saline, and possibly a salt plus a loop diuretic. I had a patient when I was in nursing school with SIADH caused by TB meningitis, and his attending team prescribed chocolate Ensure with 3 packets of salt added TID. This is that sweet and salty effect, and the resident personally tried each flavor of Ensure with each number of packets to find out which was the most palatable for the patient. So let's do another case study. A 60-year-old man is admitted with a subarachnoid hemorrhage due to a burst aneurysm. On admission, his sodium is 135, but it's 120 3 days later. He's confused and sometimes drowsy. It's typical of his injury, but there's more actually happening here. His blood pressure is high and he looks fluid overloaded. SIADH is diagnosed and he is treated with fluid restriction 900 mL per day. Lasix is also added. Alright, so let's switch tracks and talk about cerebral salt wasting. This actually has nothing to do with ADH, but we're not actually 100% sure what causes it. Possibly dysregulation of the sympathetic response or increased levels of atrial natriuretic peptide or brain natriuretic peptide. These complicated sounding things affect the kidney, and the kidney promotes both sodium and water to be excreted. So these patients have increased urine output, hyponatremia, because the sodium is leaving too, and hypovolemia, because the water is leaving at the same time. The sodium in the urine is going to be high. It's pretty common. About 57% of patients will get cerebral salt wasting after a subarachnoid hemorrhage, and between 5 and 10% of our TBI population. The workup includes looking at the kidney function, CBC and electrolytes, and checking at the urine osmolality and sodium levels. Treatment differs from SIADH. We need to restore the intravascular volume because they are hypovolemic. Salt tabs and isotonic saline might be ordered, possibly 3% if it's really severe. Now, remember I said it makes a difference how fast the sodium changes. And if we, trying to correct these things, increase the sodium too quickly, like more than 8 to 10 millimoles per liter per day, we can cause central pontine myelinolysis. The rapid rise in sodium pulls water out of the brain cells, leading to the destruction of the myelin sheath and actually dehydrating the brain. The pons and brainstem are really sensitive to this rapid rise in sodium, and patients can present with spastic quadriplegia, pseudobulbar palsy, and encephalopathy or coma. The mortality rate's pretty high, it's about 30%, and the disability caused by this can be really significant and possibly permanent. Favorable outcomes are reported in 50 to 67% of patients. Complete recovery was reported in 5 out of 8 studied patients when they were asked between 3 months or 4 years after the event. This was actually a plot line in an early season of Grey's Anatomy. The patient had a dilutional hyponatremia after a TBI, and the intern struggled to maintain the patient's fluid restriction. The patient was so desperately thirsty he drank water out of the toilet. We've definitely had issues where we've had to shut down the water to a patient's room or lock the bathroom door to achieve compliance with the fluid restriction. So the foolish intern ordered 3% saline at 500 mils per hour times 3 hours, which is way too much too fast. The patient's sodium rose so quickly it caused central pontine myelinolysis. High sodium causes cerebral edema, and it really needs to be treated in our patient populations. Patients can have hypernatremia caused by medical interventions like mannitol, or surgical procedures, or medical issues like acute kidney injury or central diabetes insipidus. When it comes to diabetes insipidus, basically, we're used to monitoring these patients, especially after they've had pituitary tumor surgery. The poor bruised pituitary is secreting too little ADH, and the kidneys are told to excrete water. These patients have high sodium levels, they look dry, and they can have low blood pressures. Urine outputs can be crazy high, from 2 to 20 liters out in a day. Specific gravities are low, less than 1.005. Treatment is fluid replacement, ideally oral, but perhaps intravenous if the patient just can't keep up. These patients are also given DDAVP, which is synthetic ADH. They're trying to tell the body to retain water. Your take-home message here is, clinically, the impact of the sodium level on the patient's presentation depends not just on how high or low the sodium goes, but how fast these changes happen. I hope this table can help you understand the differences in these 3 disorders of sodium. Remember, it's not your job to necessarily diagnose whether it's SIADH or cerebral salt wasting, but to monitor ins and outs carefully watch for those specific gravities as ordered, draw the lights or the urines as ordered, and just have an awareness that it can contribute to your patient's confusion. Ultimately, we need to watch for these signs of deterioration and report them to the attending team so they can make the diagnosis. Thanks for tuning in. Hope you have a good day. For the case study, please tune into the YouTube video I have linked in the show notes. Thanks.